Welcome to this presentation on your medical documentation matters. This presentation is a comprehensive review of Medicaid documentation policies and procedures from Evaluation and Management, EM, to discharge. It includes a case study to demonstrate how complete and accurate documentation must be in order to receive reimbursement from Medicaid for medical services. At the conclusion of this presentation, participants will identify Medicaid medical documentation rules, explain that services rendered must be well documented, and that documentation lays the foundation for all coding and billing, and describe the national impact of improper payments. The goals of this presentation are for the participant to become familiar with Medicaid medical documentation rules, discover through a case study the importance of complete and detailed documentation as the foundation for coding, billing, and quality of care for the patient, learn how poor documentation leads to improper payments, which have a negative national impact on Medicaid. During this presentation, we will discuss the importance of medical documentation. Let's begin with a quick overview of Medicaid. Medicaid is a unique program quite different from Medicare. Medicare has nationwide laws and standards that every participating medical professional in any state must follow. Medicaid programs, on the other hand, vary according to each state's statutes, regulations, and state plan within broad federal guidelines. In addition, each state has the option of developing and implementing Medicaid waiver programs. Waiver program rules can also vary from state to state and even within the same state's programs. Participating medical professionals must know and abide by the specific rules for each state where they practice and for each of the programs for which they furnish covered services. State-specific examples are cited in the presentation to illustrate the rules discussed during the presentation and may not be applicable in every state. Naturally, as medical professionals, you will want to be familiar with the nuances of the Medicaid program in the states where you furnish services. If there are any questions regarding documentation, visit your state's Medicaid website and search for the Rules and Regulation page, or Provider Handbook, or by looking it up at MedicaidDirectors.org on the National Association of Medicaid Directors website. During the presentation, we will use a progressive case study to highlight important federal and state Medicaid documentation, regulations, and rules. To illustrate these points, we will follow a patient's course of treatment through several medical services and the respective medical professional types furnishing the services. Our patient's treatment course begins with emergency transport and ends with his discharge from services. Let's get started by meeting our patient.
J.K. is a 52-year-old male patient. He is 6 feet tall and weighs 265 pounds. J.K. currently smokes 1 pack of non-filtered cigarettes per day and drinks approximately 1 case of beer per week. He was diagnosed with hypertension, high cholesterol, and type 2 diabetes at age 40. His home medications include lisinopril, simvastatin, glipizide, and metformin. His blood pressure, cholesterol, and diabetes were well controlled until approximately 2 years ago. J.K. is married, and he and his wife have 3 children under age 17. He worked as a computer programmer for a small corporation for 18 years. The corporation went out of business 2.5 years ago. Since then, he has been working part-time for a local retailer while he continues to search for full-time permanent employment in his field. His wife has been working at their church as a part-time secretary for 20 years. J.K. and his wife are ineligible for health insurance benefits through their employers. Over the past 2.5 years, their standard of living has decreased, and their savings has been depleted. The entire family receives medical services through the state's Medicaid program. J.K. struggles daily with his feelings of anger, hopelessness, and worthlessness. He has become more withdrawn, finds little joy in life, and he refuses to engage in family activities, even though he used to be the one to initiate them. His agitation is growing, and his family members avoid him. Before we get too deep into JK's case, let's take a few moments and lay the foundation for why it is so important to document medical services.
Medical professionals are in the business of helping their patients, meeting ongoing patient needs, such as furnishing and coordinating necessary medical services, is impossible without documenting each patient encounter completely, accurately, and in a timely manner. Many providers have transitioned to electronic health records, EHRs, which can be an asset in meeting documentation goals. Documentation is often the communication tool used by and among medical professionals. If a record is not properly documented with all relevant and important facts, it can prevent the next medical professional from furnishing sufficient services. The outcome can result in erratic or even dangerous treatment and cause unintended complications. Reasons for documenting medical services include meeting patient needs and complying with federal and state laws and regulations. These laws require Medicaid medical professionals to maintain the records necessary to fully disclose the extent of services, care, and supplies furnished to beneficiaries, as well as to support claims billed, thereby reducing improper payments and the problems associated with them. The purpose of EHRs is to improve healthcare quality, safety, and efficiency. EHRs allow medical professionals a seamless approach for coordinating, managing, and making medical decisions. They can help reduce paperwork, eliminate duplicate tests, and facilitate code assignment for billing. However, while EHRs can improve medical professional services, medical professionals must be cautious when using them. For example, features like autofill and auto prompts can facilitate and improve medical professional documentation, but they can also be misused. Cloning is a growing problem in healthcare. Cloning is copying and pasting previously recorded information from a prior note into a new note. Medical professionals may see a patient for the same thing repeatedly or for complications related to the same disease. As a result, many of the clinical notes may be similar. However, the medical records must contain documentation showing the differences and the needs of the patient for each encounter. Simply changing the date on the EHR without reflecting what occurred during the actual visit does not meet documentation rules. The U.S. Health and Human Services Office of Inspector General, HHS OIG, 2013 work plan indicates that its staff will be paying close attention to EHR cloning. Before we get back to our patient, there are important basic medical record documentation principles medical professionals should know and use for meeting Medicaid rules. Those rules are listed on the next two slides. A guide to general medical documentation principles can be found in the Centers for Medicare and Medicaid Services, CMS, Evaluation and Management, EM, Services Guide, which can be downloaded and printed from the CMS website. Although the EM Services Guide is directly applicable only to Medicare participating medical professionals, these principles may be useful for all medical professionals in guiding how they document their medical records. The principles include: the medical record should be complete and legible. The documentation of each patient encounter should include the reason for the encounter and relevant history, physical examination findings, and prior diagnostic results, assessment, clinical impression or diagnosis, medical plan of care, and date and legible identity of the observer. If not documented, the rationale for ordering diagnostic and other ancillary services should be easily inferred. Past and present diagnoses should be accessible to the treating and consulting physician. Appropriate health risk factors should be identified. The patient's progress, response to and changes in treatment, and revision of diagnosis should be documented, and diagnosis and treatment codes reported on the health insurance claim form or billing statement should be supported by the documentation in the medical record. Keep these principles in mind as we go through the presentation to see how they are applied. Now, let's get back to the patient.
It was a typical Friday evening. JK's family members were out, and he was home alone. When he attempted to get up from his recliner, he found he could not stand or walk due to severe right leg pain. JK was unable to reach anyone in his family by phone. After about an hour of continually trying to reach one of them, he called 911, and an ambulance was dispatched to his home. During transport to the hospital, the emergency medical technician, EMT, took a brief history from him and documented the information. The brief history included JK's chief complaint, CC, his vital signs, his current medications, and the medical need for the ambulance transport. Upon arrival at the hospital, the EMT verbally reported the information to the nurse on duty. "We will leave JK in the hands of the emergency department, ED, staff, for a few minutes while we discuss emergency transportation and documentation."
Medicaid emergency medical transportation does not require prior authorization. However, in many states, transportation providers will be reimbursed only when acceptable records verifying a trip's occurrence are complete and available to auditors upon request. At a minimum, the emergency transportation medical professional should document the patient's identifying information, the name and address of the requester, the date of transport, the location and time of pickup, the location and time of drop-off, the total number of miles traveled while the patient was in the vehicle, known as loaded mileage, the vehicle's identification number, the type of vehicle used, the vehicle license plate number, the driver's and attendant's names, including signatures, and the medical need for the ambulance. Typical documentation requirements continue on the next slide. Participating medical professionals are accountable for knowing and documenting state-specific information in addition to the information listed here. For example, New York requires emergency transportation medical professionals to complete and keep a document known as the pre-hospital care report. Illinois requires ambulance medical professionals to keep a dispatcher's log and trip ticket, and South Carolina requires the medical professional to keep a state-approved ambulance run report. The final item on the list is the requirement to document the medical need for the ambulance. All state Medicaid programs cover medical necessity under their program guidelines and limitations for each service. EMTs must document the medical need for every ambulance transport, such as the patient's chief complaint, medical history, vitals, and current medications. Since there is no general federal medical necessity definition for states, each state has the flexibility of defining it. The documentation listed on this slide is required for every leg of a trip. If any of the information is lacking, illegible, or false, a claim will be denied. Before we return to the ED and JK, let's take a few more minutes to discuss medical record documentation that is lacking or illegible. As seen previously on the CMS EM slide, all medical records should be complete and legible, including transportation documentation. According to the Texas Medicaid Administrative Code for Ambulance Services, if a participating medical professional's documentation is lacking, providers can be subject to sanctions for failure to comply with the requirements that are specific to Texas Medicaid, even if the services were furnished. Many states' Medicaid administrative codes have similar language. Making sure all medical services documentation is complete and does not lack state-specific information cannot be overemphasized. Complete documentation protects the patient, but it also protects the medical professional. A court case in Tennessee illustrates this point. On June 29, 2012, a regional hospital agreed to pay the federal government approximately $3.6 million to settle false claims allegations. Hospital transport staff documented and maintained ambulance medical records for services they furnished to patients. However, the records were missing rule-specific documentation, including medical necessity documentation, a physician certification statement, or required signatures. Participating medical professionals can be subject to various penalties and sanctions if they do not follow federal and state regulations and rules governing Medicaid, including civil, monetary, and criminal penalties, and exclusion from participation in public health care programs like Medicaid. Federal statutory and regulatory requirements are in Title 19 of the Social Security Act and the Code of Federal Regulations, respectively. State regulations are in each state's administrative code. Application of these requirements are in each state's provider manuals. What if the information is documented in the record, but the author is the only one who can read it? All handwritten medical record documentation should be legible, and that includes medical professionals' signatures. What does being legible mean? Depending on the state's administrative code, a legible medical record is one that can be read by someone other than the author or by at least two people other than the author. Medical records that other medical professionals cannot decipher are of little value. Medical professionals and auditors should be able to pick up any medical record, read it, understand the medical picture, and know who the medical professional was that documented the information. If people cannot read the record, claims can be denied. If the medical records are handwritten, consider writing the record using ink, even though there is no specific regulation requiring it. Blue ink works best. If black ink is used, it is difficult to tell if the record is an original or copy. Be sure to write the record in clear language. Use professional jargon only when it is common knowledge. Once you write a note, do not alter it. It is never appropriate to alter medical records for any reason. For example, in a podcast developed by HHS OIG, the OIG audited a medical record used as supporting documentation for billing renal failure services. The record was extensive, but there was no diagnosis of renal failure documented. OIG personnel called the medical professional and asked for an explanation. The medical professional submitted a document with chronic renal insufficiency, CRI, highlighted in the following statement: chronic pain, pathology diagnosis, CRI, renal cell carcinoma. Refer to oncology. The audit team already had a copy of the resubmitted document, and CRI was added to the patient's record long after it had been copied for the audit and long after the date on the progress note. Dr. Julie Tatesman, Chief Medical Officer at HHS OIG, stated, "If you discover you billed for chronic renal insufficiency, but the medical record does not indicate the patient ever carried that diagnosis, it may be tempting to simply add CRI to the record. But don't. The cover-up just makes it worse. If an addendum is necessary, add the information and then document the date of the addendum, not the date the service was furnished. If there is a mistake in the medical record, correct it by drawing a single line through the information, initial and date it, and then write the correct information. Do not black out text, use whiteout, or scribble information or mistakes out. Be sure to sign and date all medical record information all of the time. Let's look at the importance of creating legible EHR entries as well. The documentation for each encounter should be unique. No two encounters are ever identical, so the notes should not be identical either. This is one of the risks of EHR. Avoid using copy and paste features or autofill features based on diagnosis or other clinical code descriptions. Use the patient's own words as appropriate, or when possible to document the reason for the encounter in addition to your own clinical or professional notes. For office visits, note any changes in patient history, such as medications from or procedures performed by other providers, life events, or home and work-related stresses and accomplishments. If you've ever sent a text message or a voice-to-text message, you know the autocorrect features can misinterpret your words, sometimes to the point of embarrassment. If your EHR software allows voice-to-text, or if you use proprietary voice-to-text software, be sure to check your spelling to make sure autocorrect didn't make corrections you didn't intend. Better yet, turn off the autocorrect feature altogether. When using a voice-to-text feature, make sure you enunciate clearly and double-check the diction to make sure the software understood you correctly. Some voice-to-text software even recognizes when you tell it to insert punctuation, and will convert your spoken word to a punctuation mark to help minimize having to edit the message later. EMTs are not the only transportation medical professionals that are required to keep documentation. What about the company's responsibilities? All medical organizations have employee oversight responsibilities to comply with federal and state laws. While different organizations are responsible for different oversight, the principles are the same. We will use the transportation company as an example. First, the company must have a Medicaid medical provider agreement with the states where it offers services. The state cannot reimburse services furnished by an unapproved medical professional. Once approved, the company or hospital-based ambulance service must keep the agreement on file, meet the contractual requirements, and verify that its drivers and vehicles meet the standards set by the state. Verifying drivers' qualifications and vehicle safety offers protection for the company, its employees, and the Medicaid beneficiaries they transport. All states require transportation companies to verify their drivers' qualifications. At a minimum, companies must verify and save a copy of each individual's driving record, document that the employee has the current and correct licenses, document a criminal background check, and verify the driver has the required education, training, and certifications to be eligible to perform the necessary services required during emergency transports. In addition, the company's vehicles must be currently licensed to the correct entity, covered by the required liability insurance, and be in good working condition with the proper supporting documentation on file. Vehicle documentation must show the vehicles are regularly serviced and any mechanical problems are corrected. The vehicles must also have the necessary equipment to meet emergency needs. Ambulances must be specially designed and equipped for transporting the sick or injured. Now, let's get back to J.K. When we left him, he was receiving care from ED staff. Let's see how things have progressed since then.
The ED physician evaluated J.K. His history and physical revealed blood glucose of 260 milligrams per deciliter and a foot ulcer of approximately 2 centimeters in diameter with surrounding necrotic tissue extending 2 centimeters from the edge of the bottom of his right foot. The rest of his foot was red and warm to the touch. The redness and warmth extended up his leg to approximately 6 inches below the knee. He had no sensation in his foot with the pinprick test, and he lacked ankle reflexes. His white blood cell count, WBC, was 22,000 cells per cubic millimeter. J.K. showed signs of sepsis, so the ED physician ordered a lactate level. The ED nurse took J.K.'s vitals every 15 minutes to track the hypotension. The lactate test came back positive. The ED physician contacted the hospitalist immediately. The hospitalist admitted J.K. to the intensive care unit, ICU, started him on piperacillin, tazobactam, and vancomycin, and fluid resuscitation, and ordered an X-ray of his right leg. The X-ray showed clear osteomyelitis. The hospitalist documented wound drainage, purulence, fluctuance, odor, length of time the ulcer had been present, and that J.K. had not received any wound care prior to admission. The hospitalist immediately consulted with an orthopedic surgeon.
Before discussing the orthopedic consult, we will take a few minutes to talk about EM clinical guidelines and coding. As previously stated in this presentation, these guidelines are directly applicable only to Medicare participating medical professionals. However, these principles may also be useful for Medicaid medical professionals in guiding clinical decision-making and coding. EM codes are found in the Current Procedural Terminology, CPT, manual, and are used for billing the services furnished to patients. The codes also indicate the type of physician seeing the patient and the level of care furnished to the patient. EM principles are complex and are summarized in the following 2 slides. Physicians and other qualified medical professionals are encouraged to pursue a more thorough study and understanding of these principles. Until completely familiar and confident with the guidelines, physicians may want to download a copy or bookmark the site of the CMS Evaluation and Management Services Guide on their computers for easy access and reference. Using the CMS 1995 or 1997 EM guidelines furnishes a systematic, thorough approach that can be used for diagnosing, treating, and documenting patient care in a variety of settings. Physicians may choose to use either set of guidelines. However, they may use only one set at a time. The two sets cannot be intermingled. According to the Evaluation and Management Services Guide from the Medicare Learning Network, if it isn't documented, it hasn't been done. For example, all state Medicaid programs require every medical professional to document that medical necessity criteria has been met when furnishing Medicaid services. In addition, healthcare payers will typically require accurate documentation of the place of service and the delivery of services. Documenting medical necessity is complex and requires several steps, as outlined in the principles here and on the following slide. Perhaps the most important principle is that the medical record should be complete and legible. Missing or unreadable information may cause subsequent providers to order tests or other services that are either unnecessary or duplicative. The reason for the encounter must be documented as well, including any relevant history, findings from any recent physical exams, including the immediate one, prior diagnostic test results, and any plan of care the patient may be following. The current assessment, clinical impression, and diagnoses of the evaluating provider should be documented as well, in addition to the date of the evaluation and the name of the evaluator or observer. In addition to principles on the previous slides, follow these principles as well. The rationale for ordering any diagnostic tests or other ancillary services must be documented, or at least easily inferred from the patient's history or current complaint. Any past or present diagnosis must be readily available to treating or consulting physicians or other providers who need to know history or patient characteristics relevant to the current treatment, for example, an anesthesiologist. Any appropriate health risk factors must also be identified. The patient's primary provider or other designated provider must also document the patient's progress, responses to treatment, any changes in treatment, any revision of the diagnosis. Finally, the diagnostic and treatment codes must have sufficient support in the documentation to warrant using those codes. With these principles in mind, let's look at the three main points the orthopedic surgeon will have to consider for selecting the proper CPT-EM code. The first aspect of selecting the correct EM code that physicians must address and document is whether the patient is new or established. There are definitions for new and established patients. A new patient is one never seen by the physician or any qualified practitioner in the same group practice with the same specialty, or one that has not had services within the past 3 years furnished by the physician or any other qualified practitioner of the same specialty in the practice. An established patient is one who received services by the physician or other qualified practitioner in the same group with the same specialty within the past 3 years. In J.K.'s case, neither the orthopedic surgeon nor any other qualified medical professional in her practice had seen him, so J.K. was documented as a new patient. The second consideration for EM coding a physician generally must address and document is the setting where the patient was seen and received services. The settings a physician can choose from are office outpatient, hospital inpatient, ED, and nursing facility. The setting is simply where the physician saw and treated the patient. Based on the EM choices, the surgeon documented the service setting for J.K. as hospital inpatient, while the ED physician documented the ED. The 3 EM key components used to determine service level and complexity are history, examination, and medical decision-making. Each of these components includes subcategories that must be considered. Tables borrowed from the Evaluation and Management Services Guide will be displayed during this presentation for ease in sharing the information and explaining the elements and the subcategories associated with them. According to EM guidelines, the table on this slide depicts all of the required elements for a service to qualify for a specific history level and shows the subcategories that must be considered during the decision. The 4 levels of history are problem-focused, expanded problem-focused, detailed, and comprehensive. The subcategories are chief complaint, CC, history of present illness, HPI, review of systems, ROS, and past family and/or social history, PFSH. The CC is required for every history type and is a concise statement that describes the symptom, problem, condition, diagnosis, or reason for the patient encounter, and is normally documented in the patient's own words. The HPI is defined as a chronological description of the development of the patient's present illness from the first sign or symptom or from the previous encounter to the present. The HPI includes one or all of the body's systems. An ROS is a series of questions the physician asks in order to identify signs and symptoms that the patient may be experiencing or has experienced. The PFSH reviews the patient's previous medical illnesses, operations, injuries, and treatments, and any family history of related health issues that potentially puts the patient at medical risk, and the previous and current social life of the patient. For the patient history, make sure you consider the following. Review and update of ROS and/or PFSH obtained on an earlier encounter does not need to be recompleted, but no change should be documented. ROS and PFSH may be recorded by ancillary staff or on a patient-completed form. If unable to obtain the history, the record should describe a patient's condition or circumstance that precludes it. Each of these subcategories has elements that demand clinical judgment by the physician to determine what and how much information must be gathered. The history level cannot be determined without addressing each subcategory. As the need for information increases, so does the level of complexity a physician documents and bills. The second key component is examination. As stated earlier in this presentation, there are 2 versions of Medicare EM guidelines physicians may use, the 1995 or 1997 versions. The most substantial differences between the 2 versions occur in the examination section. It is important for physicians to take the time to learn the differences and choose which set of guidelines to use for each of their cases. Remember, the EM information can be used as a general guideline for clinical documenting and coding. Your state Medicaid program may not require you to follow these guidelines. An examination may involve several organ systems, or a single organ system. The type and extent of the examination is based on the physician's clinical judgment, the patient's history, and the nature of the patient's presenting problems. There are 4 EM examination levels: problem-focused, expanded problem-focused, detailed, and comprehensive. The problem-focused level is a limited examination of the body area or organ system affected. An expanded problem-focused level is also a limited examination of the body area or organ system affected and includes any other symptomatic or related body areas or organ systems. A detailed level is an extended examination of the body areas or organ systems affected along with any other symptomatic or related body areas or organ systems. And finally, the comprehensive level is a general multi-system or complete examination of a single organ system. When documenting general multi-system and single organ system examinations, remember to document specific abnormal and relevant negative findings of the affected or symptomatic body areas or organ systems. A notation of abnormal without any supporting information is not sufficient. Describe abnormal or unexpected findings of any asymptomatic body areas or any systems, and document normal findings related to unaffected areas or asymptomatic organ systems. A brief statement indicating negative or normal is sufficient. The third and final key component is medical decision-making. There are 4 types of EM medical decision-making. They are straightforward, low complexity, moderate complexity, and high complexity. Medical decision-making refers to the complexity of establishing a diagnosis and selecting a management option. All physicians should consider the following information when making these medical decisions: the number of possible diagnoses and the number of management options, including document initiation of or changes in treatment, and record the name of a provider to whom the patient was referred for additional consultation or treatment. The amount and complexity of medical records, diagnostic tests, and any other information must be obtained, reviewed, and analyzed, and the risk of significant complications, morbidity, and mortality, as well as comorbidities associated with the patient's presenting problems, the diagnostic procedures, and the possible management options. There are other elements and subcategories that must be considered in medical decision-making. These include whether the type of decision made is straightforward, low complexity, moderate complexity, or high complexity, the number of diagnoses or management options, and whether they are minimal, limited, multiple, or extensive, the amount and complexity of data to be reviewed, and whether it is minimal or none, limited, moderate, or extensive, and the risk of significant complications, morbidity, and mortality, and whether it is minimal, low, moderate, or high. Now that we have completed a basic review of EM components, let's look at what the surgeon documented for the consult she furnished on JK's case.
Using the hospital's EHR, the surgeon documented the consult report after examining JK. Her documentation justifies the code she recorded. The consult report reads as follows: Day of consult, 10/30/2015. Code 99222-57. CC, swollen, painful right foot and leg. HPI, JK is a 52-year-old male with known type 2 diabetes mellitus times 12 years, brought to the ED by ambulance, with acute onset of severe pain and inability to stand or bear weight on the leg. His vital signs showed a temperature of 100.7, blood pressure of 90/45, heart rate of 95 beats per minute, and a respiration rate of 20 beats per minute. He was admitted by hospital medicine service and started on piperacillin tazobactam and vancomycin. He was noted to have an ulcer on the bottom of the foot. He notes the ulcer has been present for about 2 months and has not changed in size. He has noted no drainage or odor until the last 3 days, when it has begun draining pus and had a horrible smell. He treated it with Epsom salts and Neosporin. His foot and leg have become more swollen over the last 48 hours, and he has experienced low-grade fever, chills, and nausea, as well as progressively increasing pain. His foot is numb and has been for about 2 years. HPI extended, and his pain is rated as a 10 on a scale of 1 to 10, with 1 being the least and 10 being the most. Past medical history, complete. Medical illness, hypertension, HTN, elevated cholesterol well controlled with medications times 12 years. Surgery, tonsils and adenoids, cholecystectomy. Medications, lisinopril, simvastatin, glipizide, metformin. Allergies, penicillin causes a rash. Social family history, maternal grandparents, coronary artery disease, CAD, diabetes mellitus, DM, paternal grandparents, HTN, mother, obesity, DM, CAD, myocardial infarction, MI, sister, obesity, DM, HTN, brother, MI, 45 years old. Habits, smokes 1 pack per day, times 20 years. Drinks 1 case of beer per week, no illegal or street drugs. ROS, extended. Head, eyes, ears, nose, and throat. HEENT, no visual or hearing problems, but wears reading glasses. Cardiac, no recent chest pain, palpitations, or shortness of breath. Respiratory, no dyspnea, orthopnea. Gastrointestinal, GI, positive for recent nausea, no vomiting, diarrhea, or constipation. Genitourinary, GU, no dysuria or frequency, urinates 2 times per night. Neurologic, neuro, bilateral lower extremity, LE, numbness in stocking distribution, no weakness, tremors, or seizures. Endocrine, diabetes poorly controlled times 2 years. Physical evaluation, PE, detailed. General, alert and oriented to person, place, and time. HEENT, pupils equal, round, and reactive to light. No palpable lymph nodes. Heart, regular rate and rhythm of the heart, no murmur. Lungs, clear to auscultation and percussion. Abdomen, soft, non-tender, active bowel sounds, no hepatosplenomegaly. Neuro, decreased light touch sensation in both lower extremities in a stocking distribution to mid-calf. Absent plantar reflex in both ankles. Skin, 2 by 2 centimeter ulcer on the plantar aspect of the right foot over second metatarsal head with necrotic base. Fluctuance is present to the level of the heel. Foot is warm throughout and redness extends to mid-calf. It is tender to palpation. There is purulent drainage from the ulcer with a significant malodor. The leg is red, swollen, and warm to mid-calf. Homans is negative. Foot and leg are insensate in a stocking distribution to mid-calf. The left foot has abnormal calicites across the metatarsal heads and is insensate in a stocking distribution to the level of the ankle. The skin is intact without areas of breakdown. Dorsalis pedis pulse is 1+ bilaterally. Laboratory, glucose 260 milligrams per deciliter. WBC, 22,000 cells per cubic millimeter with 17% bands. X-ray, antero-posterior, lateral, and oblique views of the right foot show bony destruction of the second metatarsal head with gas in the soft tissue. Magnetic resonance imaging, MRI. Destruction of the right second metatarsal head with soft tissue fluid extending above the ankle in the posterior compartment. There is edema in the bone of the first and third metatarsals. Impression. Osteomyelitis of the right second metatarsal, which may extend to the first and third metatarsal based on the edema on the MRI. Soft tissue abscess involving the entire plantar aspect of the right foot and appears to extend above the ankle both clinically and on the MRI. Possible sepsis. Plan. Patient requires emergent surgery for below-the-knee amputation due to the presence of abscess above the right ankle and osteomyelitis involving 3 metatarsals. Risks of infection, bleeding, phantom limb pain, stroke, MI, death, and non-healing with possible need for additional surgery were discussed with the patient and his family, and the consent was signed. After consulting with the hospitalist and completing a comprehensive history, an extended review of systems, and a detailed examination, the orthopedic surgeon recommended a limited amputation known as a below-the-knee amputation, BKA. JK's foot amputation was necessary because of osteomyelitis, the length of time the ulcer had been present, the condition of the soft tissue, and the presence of pus. The surgeon documented the condition of the wound, the progress of the abscess, the lack of treatment, and the amount of wound drainage. JK was too ill to consent to the procedure, so his wife signed the consent form. He was taken to surgery the following morning.
Each medical service furnished by a participating Medicaid medical professional generally requires a code for billing purposes. The documentation for reimbursement must support and justify the code. If the documentation does not meet these ends, the medical professional may have to return the payment. For example, in the HHS OIG podcast mentioned earlier, Dr. Tatesman described a case where the hospital's medical record did not support the claim billed. The record showed a chief complaint and vital signs. However, the facility claimed reimbursement for several X-rays. During the record review, the reviewer found no identifiable need for X-rays. There was no physical in history, no physician's orders, no X-ray interpretations, and no evidence of the use of the aforementioned information in developing a plan of care. Since none of the information existed in the medical record, there was no proof the payment made was correct, or that the hospital had the right to keep the reimbursement for rendered services. Effective October 1, 2015, medical professionals were required to move from ICD-9 codes to ICD-10 codes. The ICD-10 coding system is more detailed and complex. However, the change to ICD-10 can improve medical professional billing and reimbursement when used correctly. In JK's case, the surgeon coded CPT 99222-57 on the consult report. When the modifier 57 is added to the code, it indicates the physician used JK's history and examination to make the medical decision for immediate surgery. After JK's wife signed the consent for a BKA, the surgeon scheduled surgery for 7 a.m. the following day. The surgery was completed, and the operation OP notes were documented. Let's look at the OP notes JK's surgeon documented.
The surgeon's operation notes read as follows. OP note 10/31/2015. Pre-operation diagnosis, osteomyelitis, right foot with abscess. Post-operation diagnosis, osteomyelitis, right foot with abscess. Procedure, right below knee amputation. Anesthesia, general. Operative indications. This is a 52-year-old male with progressive pain, redness, swelling, fever, chills, and purulent drainage from a right foot ulcer. The MRI is consistent with osteomyelitis. Patient is febrile and hypotensive with an elevated WBC and left shift. Infection appears to be at or above the level of the ankle. He is indicated for a below-knee amputation. Operative procedure. Patient was taken to the operative suite and transferred from the bed to the table in the supine position. After adequate general anesthesia had been obtained, a tourniquet was placed over the right thigh and the right foot was placed into a sterile bag. The right lower extremity was prepped and draped in a sterile manner after timeout had appropriately identified the limb for surgery and the patient. Patient was being treated with antibiotics and further prophylaxis was not given. The right limb was elevated for exsanguinations and the tourniquet was inflated to 250 millimeters of mercury. The anterior and posterior flaps were drawn on the leg, with the anterior flap being approximately 10 centimeters below the tibial tubercle. The anterior incision was made, followed by the posterior incision. Hemostasis was obtained with electrocurettage. The anterior flap was deepened to the tibia, and the tibia was isolated circumferentially. Using an oscillating saw, the tibia was transected at the level of the anterior flap. The fibula was then isolated and transected 2 centimeters proximal to the tibia. The posterior flap was developed using an amputation knife. The specimen was passed off the table. Vessels were identified and clamped. Each was tied with zero silk. The sciatic nerve was identified. It was pulled taut, transected, and allowed to retract in the soft tissue. The tourniquet was released after 12 minutes, and further hemostasis was obtained with ties as needed and electrocurettage. The wound was irrigated with normal saline. No pus was identified in the wound. A 5/8-inch Penrose drain was placed in the wound. The deep tissue was closed with 0 vicryl, and the subcutaneous tissue was closed with 2 0 vicryl, and the skin was closed with staples. Flaps were warm and pink with quick capillary refill. The wound was dressed with Zeroform, fluffs, Curlix, and an ACE wrap. The patient was transferred to recovery in stable condition. Estimated blood loss, 50 ml. Fluid, 100 ml. Tourniquet time, 12 minutes. Urine output, 100 ml. Specimen, leg to pathology. ICD-10, CM, M86.19. CPT, 27880. The surgeon coded ICD-10 CM M86.19 and CPT 27880. The ICD-10 CM code M86 is used for osteomyelitis, and the .19 is added to signify the osteomyelitis is in multiple sites, the right ankle and the right foot. The CPT code indicates the surgical procedure used for a leg amputation. Any medical professional can pick up the surgeon's OP notes and have a picture of what occurred before, during, and after surgery. Let's look at the surgeon's post-surgery documentation and coding that occurred during JK's inpatient stay. Using the hospital's EHR system and SOAP notes formatting, subjective S, objective O, assessment A, and plan P, the surgeon documented the following information post-surgery pertaining to JK, listing no codes, but citing no charge, global, to indicate it is part of the bundled service for the global surgery code. Postoperative day, POD, number 1, 11/1/2015. S. Complains of residual limb pain, 8 out of 10 at the worst. Controlled with patient-controlled anesthesia, PCA, morphine. O. Afebrile, vital signs stable, VSS, BP 130/85. Dressing with moderate bloody drainage. Complete blood count, hemoglobin, HGB 9.4, WBC 12,472, glucose 130. A. Stable following BKA. P. Remove Foley, discontinue antibiotic, begin physical therapy, PT for range of motion, ROM of knee, straight leg raise, SLR, and independent standing and bed-to-chair transfers. Diabetes education. No charge. Global. POD number 2, 11/2/2015. S. Pain is improved to 4 out of 10. O. Afebrile. VSS. BP stable. HGB 9.0. Blood cultures negative. Echocardiogram. Echo. Showed no valvular lesions. Wound clean with minimal bloody drainage. A. Stable. P. Continue PT. Begin daily stump wraps. Discontinue PCA. Oral pain meds. Case management for discharge. DC planning. DC Penrose drain. Begin Lovenox for deep vein thrombosis. DVT prophylaxis. No charge. Global. POD number 3. 11/3/2015. S. Pain is controlled to 2 out of 10 most of the time. He is experiencing phantom limb pain, which is worse at night. O. Afebrile, VSS, HGB 8.8, WBC 8,453, glucose 120. Patient able to maintain SLR during dressing change. ROM of knee 0 to 90, wound clean and dry. A. Stable post-op course. P. Add Elavil for phantom limb pain. Continue PT. Transfer to acute rehab when bed available. No charge. Global.
JK was admitted to the hospital on October 30th, 2015, and he was discharged from hospital surgical services on November 3rd, 2015. According to the surgeon's hospital documentation, she may bill for the initial inpatient consult, CPT 99222-57, as well as the surgery. However, she coded no billing charges for the inpatient days she saw JK post-surgery, even though she saw him daily, because of a billing practice known as global surgery. Global surgery is a term used to indicate that the technical and professional medical services are billed together rather than individually, and includes all necessary services normally furnished by a surgeon before, during, and after a procedure. The time JK's surgeon spent with him post-surgery, up to 90 days, was covered under the surgical code billed. In JK's case, the surgeon will bill her own services and is accountable for ensuring her documentation justifies the services on any claims she submits. The hospital will submit claims to Medicaid for JK's hospital stay, and the hospital-based physician services, for example the ED physician and the hospitalist. In this case, both the hospital and the physicians are accountable for ensuring the documentation justifies the services on the claims submitted. The hospital will bill JK's inpatient stay. The facility can bill for the day of admission, even though it was late in the evening, but cannot bill services the day of his discharge. If a patient is admitted to the hospital at 11:47 p.m., an entire hospital per diem is paid. On the other hand, even if a patient does not leave the hospital on the day of discharge until 11:59 p.m., the hospital may not count it as an inpatient day. Physicians who receive reimbursement from Medicaid, whether directly or not, are generally expected to document a discharge summary that includes follow-up care. Let's look at what J.K. Surgeon documented.
A discharge summary includes the patient outcome after hospitalization, the case disposition, and the patient's follow-up care plan. The hospital shall utilize an effective and ongoing discharge planning process that identifies post-hospital needs of inpatients and arranges for appropriate resource referral and follow-up care. J.K.'s discharge summary reads as follows. Discharge summary. Admit date 10/30/15. Discharge date 11/3/15. Discharge diagnosis osteomyelitis right foot. Secondary diagnosis type 2 diabetes mellitus, hypertension, elevated cholesterol. Hospital course. This is a 52-year-old male who presented to the emergency room with fever, chills, pain, and purulent drainage of the right foot and leg. Admission lab showed an elevated white count with a left shift and elevated glucose. X-rays and MRI were consistent with osteomyelitis of the foot. Infection appeared to extend above the ankle, and the patient was hypotensive on admission. He was treated with broad-spectrum antibiotics and fluid hydration. He was stabilized and taken to the operating room for BKA under general anesthesia. Piperacillin tazobactam was continued for 24 hours postoperatively for infection prophylaxis. Postoperatively, his blood glucoses stabilized and he was given diabetes instruction. He remained afebrile, blood cultures were negative, and his hemoglobin remained adequate. Echo was negative. Physical therapy was started on his first postoperative day for range of motion, independent transfers, standing in parallel bars progressing to a walker, and quadriceps strengthening. He tolerated physical therapy well, and by the third postoperative day was independent with bed to chair, able to maintain a straight leg raise, and had a range of motion of the knee 0 to 90. His wound was clean and dry throughout the postoperative course. A Penrose drain was removed on postoperative day 2, and stump wraps were started on postoperative day 3. Pain was initially controlled with PCA morphine, which was discontinued on postoperative day 2. The patient developed phantom limb pain treated with Elavil. He was given Lovenox for DVT prophylaxis. Case management was consulted for discharge planning to rehabilitation unit. On the fourth postoperative day, the patient was stable, tolerating an 1,800-calorie American Diabetes Association diet, and was transferred to acute rehabilitation for continued physical therapy, daily stump wraps, shrinker fitting, prosthetic fitting, and gait training. Prosthetics will evaluate for prosthesis and make recommendations. Discharge medications: lisinopril, 20 mg PO daily, simvastatin, 20 mg PO daily, glipizide extended release, 5 mg PO, 3 times daily, 30 minutes before each meal, metformin, 750 mg PO twice a day, Lovenox, 40 mg subcutaneously daily for 3 weeks, Elavil, 50 mg by mouth at bedtime for phantom limb pain, number 30, hydrocodone, acetaminophen, 325 mg, PO, every 3 hours when necessary for pain, durable medical equipment, DME, walker, wheelchair. He will return to my office in 3 weeks for wound check and suture removal. He was referred to Dr. Stevenson in 1 month for follow-up of his diabetes. He will follow up with Dr. Dillard in 1 month for hypertension and elevated cholesterol. Code 99238. The surgeon coded CPT 99238, which means Hospital Discharge Day Management 30 minutes or less. In this case, it took the surgeon less than 30 minutes to document JK's discharge summary.
Medicaid typically pays for rehabilitation, rehab, in an acute care setting when it is medically necessary, and when it is to treat an acute condition or an acute exacerbation. When J.K. was transferred within the hospital to the rehab unit, his assigned physical therapist was responsible for developing a treatment plan. According to the journal Prosthetics and Orthotics International, an important basis for optimal acute and long-term management of amputees is an in-depth understanding of the patient and the functional consequences of the amputation, systematic and detailed consideration of the patient and their environment, and sound measurement of functional outcomes. This information should be documented on the treatment plan for best results. A physical therapy, or PT, treatment plan should include at least the following information, predicated on where the physical therapist works and the states where he or she practices: beneficiary's name, beneficiary's Medicaid identifier, diagnoses, date of onset or date of the acute exacerbation, surgery performed if applicable, date of surgery if applicable, functional status before PT started and after PT is completed, frequency and duration of treatment, modalities used, documentation of any ulcers, including the location, size, and depth.
Physical therapists generally are required to document their treatment plan in daily notes, and they must be in accord with the attending physician's plan of care. The ordering physician is required to sign the physical therapist's treatment plan. The plan and the notes must be readily available in the medical record. In J.K.'s case, the physical therapist documented using the hospital's computer system immediately after meeting with him each day. The documentation was automatically timed and dated by the hospital's EHR system, and the physical therapist was able to electronically sign the record at the time he completed it. J.K.'s treatment plan included stump shaping, stretching his leg and hip muscles to maintain his range of motion and prevent a second disability, daily stump wraps and shrinker for wound care and to decrease swelling, skin care education in preparation for prosthetic use, cardiovascular training, strength training, gait training, balancing, turning around, leg weight bearing, and using a walker until the stump healed adequately for prosthesis fitting. The physical therapist, along with the rehabilitation team, made a recommendation to J.K.'s surgeon for a sac foot, pylon, socket, and suspension to be delivered once the stump completely healed. The swelling was gone, and the stump was conical in shape. The surgeon agreed and faxed the signed order to the DME medical professional. Medicaid hospital rehab is paid at a level per diem rate, according to that state's formula, times the number of days the patient is on the unit. J.K. was transferred to the rehab unit on November 3rd, and he was discharged on November 12th. The hospital will bill for 9 days of inpatient rehab. Once again, the unit receives payment for the day of admission, but not the day of discharge. Since the physical therapist works for the hospital bills for the services furnished. The hospital bills its claims electronically using the electronic claim format Accredited Standards Committee, ASC, X12N837 institutional form. However, if the hospital billed paper claims, it would bill on the CMS 1450 form, also known as the UB04. Both the hospital and the physical therapist are responsible for what is billed on the claim. Each state may have specific information it requires the biller to include on the form. If you have billing questions, check with your state Medicaid agency, SMA. After 10 days in the rehab unit, J.K. was discharged to home. J.K.'s prosthesis was not fitted during his stay in the unit. His stump needed more time for the swelling to go down, shaping, and to completely heal. In preparation for his return home, the hospital case manager met with J.K. and his wife several times. The case manager coordinated the post-hospital medical necessary services for him. She scheduled a follow-up appointment with his surgeon and a home visit from a DME medical professional for prosthetic fitting, education, and training. She also recommended a referral for outpatient mental health services based on a depression index she administered during J.K.'s inpatient stay, comments made by his wife, and observation of J.K. and his interaction with others. He agreed to the follow-up appointments with the surgeon and the DME medical professional and he reluctantly agreed to in-home mental health therapy after his wife pressured him. The case manager made the initial appointments for him before he left the hospital. At home, J.K. continued the stretches his physical therapist taught him. He moved his stump often to increase circulation, help prevent stiffness, and decrease contractures and phantom pain. He continued his exercises, and as his stump healed, he conditioned it to prepare for his new prosthetic. After being home for about 5 weeks, he was motivated to be fitted for his prosthesis. The DME medical professional arrived at JK's home as scheduled, but before he went, he completed several medical professional responsibilities, making sure all of his ducks were in a row prior to furnishing any services. The first thing he did was check the state's eligibility system to see if JK was still eligible for Medicaid benefits. Since Medicaid is a month-to-month insurance program, medical professionals can never assume a beneficiary is still eligible and are encouraged to check member eligibility monthly. Even if the services are necessary, the state cannot pay for them if an individual is not eligible. The second thing the DME medical professional did was check his files. DME medical professionals bear great responsibility for ensuring they have the required documentation on file. For a lower limb, LL prosthetic, the limb must be medically necessary. An item is necessary when it can be expected to make a meaningful contribution to the treatment of a specific illness or injury, or to the improvement in function of a malformed body part. A physician's or other state-authorized medical professional's prescription can serve to document the need for an LL. For a prescription to meet state medical necessity criteria, it must include the diagnosis, prognosis, and the length of time the item is required, and be signed and dated by the ordering medical professional. In Medicaid, DME is available only based on a physician's order, either in a plan of care or prescription. In some states, prior authorization may apply for some types of DME, and generally, a request for prior authorization should include enough medical information for an independent conclusion that the requirements for the equipment or device are met and the item is medically necessary and reasonable. States have forms medical professionals must use to request prior authorization, and the DME medical professional is responsible for having state-specific proof in his or her files showing the item had prior authorization. Proof differs by state. One state may require the medical professional to reference the prior authorization number on all claims submitted, and another state may require a producible prior authorization approval letter. Check with your SMA for specifics. Once the DME medical professional verified he had all the necessary documents on file, he was ready to keep the scheduled appointment with JK. During the DME medical professional's visit, JK was evaluated and fitted for his new LL. Note that the DME medical professional was a board-certified prosthetist, which is required in some states. The medical professional documented JK's functional level at 2, which was supported in the clinical documentation from the rehab unit, and fitted him for his prosthesis. It took 8 days for JK to receive his prosthetic. The DME medical professional returned to JK's home with the LL and adjusted it to fit. He then took the time to educate JK and his wife, covering the topics of 90-day repair coverage and adjustments, the care of his prosthesis and liner, how long he should wear his LL and shrinker daily, and what he should do if his residual limb becomes sore or there's broken skin. He also advised JK to seek outpatient PT for additional gait training. Before the medical professional left, he asked JK to sign a document proving the prosthetic was delivered, gave him his number, encouraged him to call with any questions or concerns, encouraged him to attend outpatient PT, wished him well, and left. The DME medical professional can bill his furnished services either electronically on Form ASC X12N 837 professional form, or by paper claim on the CMS 1500 form. The DME medical professional is responsible for what he bills on the claim and should make sure his or her files are complete for every order. Some states require the medical professional to submit documentation with the claim. It depends on the item billed. All DME medical professionals must retain the filed documentation according to the record retention rule for the state where the services are furnished and submit records to the SMA if requested. If you have billing questions, check with your SMA. Throughout the course of JK's illness, he received several medical services. The final service furnished to JK that we will discuss is mental health services.
JK was reluctant to meet his in-home therapist and told his wife emphatically several times before she arrived that he was not crazy. When the licensed independent mental health practitioner arrived at the house, JK repeated what he had been saying to his wife. His wife quietly acknowledged the conversation and agreed he was not crazy. She then added her belief that JK had been depressed for years. After making her assertion, she quickly excused herself from the room. The therapist noted the reaction JK had to his wife's declaration. All states furnishing mental health services use the Diagnostic and Statistical Manual for Mental Disorders, DSM. DSM is the standard classification of mental disorders used by mental health professionals in the United States and contains a listing of diagnostic criteria for every psychiatric disorder recognized by the U.S. healthcare system. In the past, states paid for mental health services on a fee-for-service basis, and some still do. However, today many states offer mental health services through managed care benefits. SMAs generally do this in an attempt to control costs while furnishing quality benefits and services to Medicaid members. Regardless of whether a state pays for mental health services on a fee-for-service basis or on a managed care basis, they use some generally accepted Medicaid standards. First and foremost, in most states, there must be some documentation that the mental health services are medically necessary. Each state has the flexibility of defining medical necessity, and definitions do vary. It is the medical professional's responsibility to know the subtleties of the definitions in the states where they practice. Generally, the state has the responsibility to ensure that the beneficiary has the option to receive services at the least restrictive level. This responsibility passes on to the participating medical professional to the extent that the medical professional acts as a gatekeeper or is involved in placement or discharge planning for the individual on behalf of the state. What does this responsibility mean? It means that if an outpatient program is sufficient to meet the individual's needs, that person should have the option to not be hospitalized. Mentally ill patients should only be required to be hospitalized if there is no other way to meet their needs. Common language used to describe the need for hospitalization is the phrase, "if a person is a risk to self or others." In that instance, hospitalization may be the only option. A Medicaid beneficiary should never be required to be hospitalized for convenience. Recent changes in Medicaid rules have expanded the options for place of service. Check with your SMA for qualifying places of service. Most states require that mental health medical professionals, even when providing services through managed care plans, to keep clinical records of the services furnished to Medicaid beneficiaries. States can determine the length of time participating medical professionals retain records, but if the state does not have a rule determining the length of record retention, such medical professionals may, at their discretion, want to consult with health law counsel. Additional requirements may apply when services are provided through managed care. Now that we know the general rules that apply to mental health services, let's talk about the services JK received.
JK's state Medicaid benefits are furnished through an MCP. His benefits package allows him to seek up to 5 mental health sessions with a qualified professional of the healing arts without prior authorization. However, the MCP expects the medical professional to register the visits. By registering the visits, the MCP can track the number of sessions per year. If additional services are required at the end of the 5 sessions, the professional must obtain prior authorization through the MCP. The program is called the Client Assistance Program, and is similar to an Employee Assistance Program, EAP. JK's case manager referred him to the Medicaid Client Assistance Program because the program is specifically designed to help beneficiaries deal with personal stressors that are interfering with their general well-being. The Client Assistance Program does not require an Axis I diagnosis or a formal treatment plan. During their initial meeting, the therapist alleviated JK's fears related to therapy and explained the principles of solution-focused brief therapy. She explained the therapeutic focus is not on the past, but instead focuses on the present and the future hopes and desires of the individual. The therapist encouraged JK to imagine his future as he would like it to be. Together, they determined the steps and strategies he would need to take to make his desired future a reality. JK and his therapist met every other week for 10 weeks. JK progressed nicely through the 10 weeks. He completed assignments weekly that would take him closer to his goal. His relationship with family improved, and he slowly started re-engaging with family members. He agreed to begin participating in family game night. He signed up for classes at the local community college to update his programming skills, and he joined the local YMCA under the hardship program. At discharge, JK and his therapist reviewed his progress. They discussed the gap between where he was and where he is going, and the additional steps he still needs to take. She left an emergency number for future reference and reminded JK of his benefits should he need them in the future. The CAP services furnished to JK do not require the same level of documentation as other mental health services. The therapist is required to document each session, any progress made, and sign and date the notes. The services are paid based on a professional fee schedule and billed on the paper claim form CMS 1500. Claims must be filled out completely, or they can be denied, and then submitted to the state's Medicaid program. JK's state Medicaid program requires the claim to be submitted within 60 days of furnishing the service. Medical professionals should consult their state provider manual or contact the state where services are rendered to meet important reimbursement deadlines. Case closed.
J.K. benefited greatly from the Medicaid services he received throughout his illness. The medical professionals followed all of the federal and state rules related to documentation in the states where they practice, and they were paid for their excellent work. Let's spend the last few minutes of this presentation discussing the national significance of medical professional documentation as it relates to the Medicaid program and improper payments. Medicaid furnishes healthcare benefits to more than 50 million beneficiaries who typically would not have access to healthcare without the program. The federal-state cost of Medicaid services for fiscal year 2014 was nearly $476 billion. Over the past 2 decades, Medicaid spending has grown by 450%. Each American has a stake in the Medicaid program and how the funds allocated for the program are used. All Americans are responsible for paying taxes that fund the Medicaid program. Government representatives are responsible for program oversight and for the wise use of allocated funds. Beneficiaries need the services furnished through their state Medicaid programs and are responsible for the wise use of their benefits. Medical professionals are reimbursed for services they furnish according to federal and state laws. While every American has a stake in the Medicaid program, medical professionals have specific responsibilities when they accept reimbursement from a government program. Medical professionals must remember their documentation is open to scrutiny by many, including their employers, federal and state reviewers, and auditors. Medical professionals will be held accountable for anything billed improperly under their National Provider Identifier, regardless of who does the billing. Providers have a duty to ensure that the claims submitted to federal health care programs are true and accurate, and the law mandates that public health care payers recover funds for unsubstantiated claims improperly made. Each year in the United States, healthcare insurers process over 5 billion claims for payment. Many of the claims submitted are reimbursed improperly. The Government Accountability Office defines improper payments as those made for treatments or services that were not covered by program rules, that were not medically necessary, or that were billed for but never provided. In 2014, Medicaid improper payments totaled approximately $17.5 billion, or 14% of all government improper payments. The numbers shared may seem a bit overwhelming, but medical professionals can play a significant role in reducing Medicaid payments improperly made. Current federal regulations require that Medicaid managed care plans have a compliance plan in place. Under the Affordable Care Act, all Medicaid, CHIP, and Medicare providers will be required to have a compliance program that conforms to elements established by the Secretary of the U.S. Department of Health and Human Services. Many SMAs have adopted this requirement for all contractors and providers. While the Secretary has not yet established these elements, the HHS OIG created guidelines for voluntary compliance programs for different segments of the healthcare industry that include 7 components. HHS OIG encourages medical professionals to develop a compliance program which will serve as a positive step toward assisting providers in preventing the submission of erroneous claims or engaging in unlawful conduct involving the federal healthcare programs. A compliance program is a comprehensive set of guidelines a medical professional uses to operate their practice. It is a thoughtful, systematic way of doing business. A compliance program can reduce medical professional and practice risks, such as the receipt of improper payments or hiring excluded individuals. Medical professionals are encouraged to learn more about compliance programs by visiting the HHS OIG website at the website shown on this page. Those medical professionals who do not have the funds or staff available for developing and implementing an entire compliance program may want to implement 2 important protective practices. These practices are performing self-audits and checking for exclusions. How is a self-audit conducted? There are 5 basic self-audit rules medical professionals can use to get started. The first thing a medical professional can do is develop and implement a solid medical record documentation policy if there is not one already in place. Even if there is one, make sure the policy standards cover Medicaid federal and state regulations. The policy should address what actually happens in your everyday practice. Second, develop or use one of the available standard medical audit tools. The tool should cover the documentation policy criteria and coding standards as part of the review. Third, choose a staff member who understands documentation and coding principles to select a random sample of records for a specific time. Decide how many records should be reviewed, and then pull every nth chart for that period. Fourth, medical professionals should not personally perform their own self-audits. Resist being the one to choose and audit the charts. Most medical professionals can read their own writing and understand the meaning of the records they wrote, even if the documentation is not actually in the record. Removing bias is important. For best results, make the audit as realistic as possible. The fifth and final rule is to use the self-audit results for improving practice compliance. There is no real value in conducting a self-audit unless discovered issues are resolved. Review and analyze the audit finding. Identify the common documentation, coding, and billing problems and how they can be solved. Then, educate staff members and hold them accountable for making changes. This graphic depicts a standard monitoring and auditing process. Decide on a universe of records to check, such as all patients seen in July, or all Medicaid-only patients, and then check a sampling of records from that universe. For internal monitoring of documentation, do the following. Identify risks in documentation. For example, issues with timeliness, completeness, autofilling, keywords for monitoring. Select a standard audit tool to use regularly to perform a baseline audit. Develop and update an ongoing monitoring plan. Monitor identify risks. Take corrective action and recognize new risks. Adjust monitoring and audit processes. Return to Step 1 or continue to Step 7 as appropriate. Identify risks for the audit, audit identified risk areas, review audit results, take corrective action, and recognize new risks. Return to Step 1 or Step 7 as appropriate. For more information on auditing EHR records, please review the Conducting Internal Monitoring and Auditing Job Aid. The second protective strategy medical professionals may want to implement is checking for excluded parties. Having an excluded individual on staff is a common risk. If medical professionals receive government reimbursement for services, they need to be sure none of their employees or contractors have been excluded from participating in federal health care programs before hiring them. Federal health care programs will not pay for items or services furnished, ordered, prescribed, or supplied by an excluded individual or entity. Furnished is a key word. It refers to items or services provided or supplied, directly or indirectly, by an excluded individual or entity. For example, if a front office employee is excluded, all claims submitted by the practice may be considered overpayments subject to recoupment. In addition, the practice may be liable for civil monetary penalties and possibly exclusion from future participation in Medicaid and other federal health care programs. HHS OIG has the authority to exclude individuals and entities for various reasons, including conviction of certain crimes, loss of license for reasons having to do with professional competence or financial integrity, or participation in conduct prohibited by Medicaid rules. Almost anyone can face exclusion, whether the individual is an unlicensed biller or a licensed physician. To prevent hiring excluded individuals or entities, medical professionals are encouraged to implement a process for screening staff and contractors. CMS recommends that medical professionals check for exclusions on a monthly basis. When HHS OIG excludes individuals or entities from participation, it places their names on the list of excluded individuals and entities, LEIE. In the past, medical professionals were also encouraged to check the Excluded Parties List System, EPLS, now incorporated into the System for Award Management, or SAM. SAM combines the federal procurement systems and the catalog of federal domestic assistance into one new system, and includes the functionality of the Central Contractor Registry, Federal Agency Registration, Online Representations and Certifications Application, and the EPLS. SAM is a federal government site and is intended to streamline information for medical professionals. Check the LEIE and SAM by visiting their respective websites as shown here. Performing self-audits and checking for exclusions are important strategies medical professionals can take to protect themselves and their practices and to assist in eliminating improper payments. These strategies can be accomplished by setting aside one afternoon a month to complete these tasks. There is one final protective strategy all medical professionals should implement. Report any suspected fraud, waste, or abuse. If you see behavior that causes concerns that another medical professional, a beneficiary, or some other entity may be engaging in suspect practices, several options are available for reporting. These include the SMA, the Medicaid Fraud Control Unit, MFUCUs, and HHS OIG. Contact information for SMAs and MFUCUs is available on the CMS website. HHS OIG can be reached by calling 1-800-HHS-TIPS to report suspect practices. If you suspect a beneficiary issues such as card sharing or eligibility fraud, report it to your SMA. All medical professional services furnished, coded, and billed should be supported and justified by the documentation in the medical record. Documentation done well improves patient care and safety and protects the medical professional. By following Medicaid documentation regulations and rules, medical professionals can play a pivotal role in reducing and eliminating improper payments. Medicaid improper payments cost billions of dollars per year and affect every American citizen. Documentation improves when medical professionals implement simple, day-to-day strategies, such as performing self-audits and checking for exclusions. These strategies can go a long way in preventing problems or inadvertent errors that could cause an oversight agency to come knocking on the door. The strategies furnish a solid structure for meeting Medicaid rules and regulations and place the medical professional in a better position to respond to outside inquiries and oversight. This presentation was current at the time it was published or uploaded onto the web. Medicaid and Medicare policies change frequently, so links to the source documents have been provided within the document for your reference. This presentation was prepared as a service to the public and is not intended to grant rights or impose obligations. This presentation may contain references or links to statutes, regulations, or other policy materials. The information provided is only intended to be a general summary. Use of this material is voluntary. Inclusion of a link does not constitute CMS endorsement of the material. We encourage readers to review the specific statutes, regulations, and other interpretive materials for a full and accurate statement of their contents. December 2015.